You can start, sir. Hello. Hello. Am I audible?
Lexicon team, can you hear us?
Yes, I can hear you. Can you hear me? Hello.
We can't hear you. Okay, we'll start then. Good afternoon, everyone, and welcome to this week's PG Masterclass. For today, we have Dr. Rizwana, finally a postgraduate, discussing a respiratory case. And we have our esteemed faculty, Professor Samuel George Hanstack, head of the Department of Medicine, and Professor Richa, who is head of the Department of Respiratory Medicine. I hereby hand over to Professor Hanstack to take over this proceeding.
Thank you, Dr. Jonathan, and thank you for all of you for joining for this master class. We have a case today that will be discussed by Dr. Rizwana as mentioned. So I'll give this time to Dr. Rizwana. Our format will be is you'll present your history, and after the end of the history, we'll put in your differentials, we'll pause, have a little discussions, then you will go ahead with the examinations, then you'll expand your diagnosis, and then we'll discuss that. So over to you, Dr. Rizwana.
Video కూడా ఆన్ చేసుకో. Good afternoon, everyone. Today I am discussing a respiratory case. Presenting Mr. X, who is a 67-year-old gentleman who owns a chemical fertilizer and a pesticide shop from West Bengal, presented with complaints of breathlessness on exertion for the past 6 months with non-productive cough for the same duration. So going on to the details, Mr. X, he was apparently well till 6 months back when he developed shortness of breath on exertion. The onset was insidious and it was progressive from MMRC grade 1 to 2. And he also noted decrease in effort tolerance from 2 kilometers to 500 meters in the past 6 months. There was no associated orthopnea or paroxysmal nocturnal dyspnea. He also experienced dry cough, which was also insidious in onset, and it was associated with minimal mucoid expectoration occasionally with no postural, diurnal, or seasonal variation. He also noted 2 episodes of streaks of blood in the sputum, around 2 to 3 ml, twice, 15 days prior to the presentation. There was no history of wheezing. He also gives history of loss of weight, 6 kilograms in the past 1 year, associated with loss of appetite. He had lost weight from 60 kgs to 54 kilograms.
Are we going ahead with questions in between? Or?
There was no history of chest pain, palpitations or syncope. There was no history of dry eyes, dry mouth.
Am I audible?
Joint pains, skin rashes, skin thickenings, or Raynaud's phenomenon. Past history, he was diagnosed with type 2 diabetes mellitus in 1998 and has been on oral antidiabetic agents regularly. He was also diagnosed with coronary artery disease in 2008, which was conservatively and medically managed. He was admitted for pancreatitis and managed medically in 2021. There was no past history of pulmonary tuberculosis or ATT use in the past. He gives history of allergic rhinitis since childhood, which gets exacerbated on exposing to dust and cold weather. And there was also history of allergy to bleaching powder. Occupational history, he owns an agrochemical fertilizer and a pesticide shop, which he has been exposed to with inadequate mask or personal protective equipments for the past 50 years. Personal history, he smokes cigarettes as well as BDs 10 to 12 per day for the past 50 years with 50 pack years and a smoking index of 500. He's married and has 2 children and consumes both vegetarian and non-vegetarian diet, and his bowel and bladder habits are normal. And family history wise, his father had suffered liver cirrhosis and mother had an endometrial carcinoma. His elder sister also has diabetes mellitus and coronary artery disease. So coming to the end of the history, my summarizing, he is a 67-year-old gentleman who is a chronic smoker and works in a agrochemical fertilizer pesticide shop, presented with a complaints of 6 months history of dyspnea on exertion and chronic non-productive cough, with 2 episodes of streaky hemoptysis and with loss of weight and appetite. There was no history suggestive of CTD, and past history was significant for only type 2 diabetes mellitus, ischemic heart disease, pancreatitis, and allergic rhinitis. So with this history, my localization is to lung parenchyma or a pleural disease, because he gives history of a dyspnea on exertion, which is chronic and it's been progressing, and the cough is non-productive, which slightly excludes an airway disease and which does not have any postural, diurnal, or seasonal variation. And so my localization with the history will be a parenchyma bar a pleural disease, and pathology could be a fibrosis or an inflammatory process going on for past 6 months.
Can you hear me, please?
Dr. Rizwana, why do you suggest this could be fibrosis based on just the clinical history?
Um, Predominantly, his symptoms are progressive dyspnea and a dry cough.
Right.
So that's why.
But there is hemoptysis as well. He's a
Yes.
smoker. And why don't you think that there could be something more? This could be malignancy related. It could be infection as well.
Yes.
TB or something which is very common in our country. Weight loss is there, breathing difficulties there. Okay, and hemoptysis is there. So fibrosis at the moment, fibrosis, what fibrosis? Pleural fibrosis, parenchymal fibrosis?
At the moment, we cannot differentiate. for
Exactly.
now.
So making a diagnosis of fibrosis at that point, at this point of time is absolutely not warranted. You can say, you can localize, yes, it is in parenchyma, appears to be because you have cough is there, hemoptysis is there. So parenchyma, I agree.
Can you hear
Pleural-
me, please? Excuse me. Am I audible?
Yes, yes, you are audible.
Yeah, thank you. Shall I?
Yes, please.
Yeah, Dr. Rizwana, a very important point Madam told. I would rather put it in this way. When a patient has respiratory symptoms, predominantly we have respiratory symptoms of cough, breathlessness. These are the chest pain. All these are the common respiratory symptoms. But when the patient has hemoptysis, it is clinically ideal to think around hemoptysis, because that is a devastating symptom and not many respiratory diseases are associated with hemoptysis. And most of the times this disease that produces hemoptysis is very sinister. So in most of the patients with respiratory disease will have cough, many of them will have breathlessness. These are all common common symptoms in most of the diseases. But when the patient complains of blood in the sputum, it's very horrifying for the patient and it's very important for the clinician to think around that. Could you please tell us common causes of hemoptysis?
Yes, sir. Causes can be bronchiectasis, tuberculosis, or
In India, it's better to start, we are all old-time people, better to start off with pulmonary tuberculosis and then what is the next one? Bronchiectasis comes lower in the list. Always, as a postgraduate, you should tell the most common ones first and then downwards.
after pulmonary tuberculosis, it could be malignancies,
Yes.
bronchogenic
Then,
heart.
then
Then
the third one,
pulmonary AV malformations, mitral
very
stenosis.
rare, very rare. Suppurative lung diseases, particularly bronchiectasis. So in that order, so among these 4 or 5 common causes of hemoptysis, which one will have associated breathlessness? Because if you look at the history, it's breathlessness that started first, according to your history, right?
Yes. Yes.
Yeah. So which one of these can have breathlessness as an important initial symptom?
Again, pulmonary tuberculosis also can have.
I would rather ask you to think a little focused, because pulmonary tuberculosis is an etiology. It can affect the lungs in many ways, isn't it? So what are the ways in which tuberculosis affects the lung? What all it can produce in the lung? It's an etiology, mycobacterium tuberculosis, that's all. So in which all ways tuberculosis can affect the lung?
Um, it can cause pleural effusion.
Very rare. More than that, direct infection causes what is the commonest form of lung involvement? Commonest form of lung
Cavity.
involvement due to
Cavity.
parenchyma only.
Parent-
Cavity, yes. Then,
Um,
do you think pleural tuberculosis or pleural effusion is a direct infection?
no, sir.
Yeah, so that is actually it's a reaction, isn't it?
Yes.
So after cavity, what is a common way in which tuberculosis bacillus affects the lung?
Can lead to bronchiectasis.
No, bronchiectasis.
I mean,
No,
as a
no.
post-TB sequelae.
That is post TB. I'm asking about acute infection. Post TB, upper lobe sicca, and all those. That's not the direct infection you mean. What are the other ways in which tuberculosis affects the lung? Cavity is very common. What else?
It,
Hmm?
miliary tuberculosis.
Yes, miliary. Can it
Mhm.
produce fibrosis?
Yes, sir. Late.
Can
Yes,
it, can it produce fibrocavitary? Both.
yes, sir. Yes, sir.
Yes. Can it produce infiltrative tuberculosis? Not
Yes,
miliary.
yes, sir.
Yes. Can it produce consolidation?
Yes, sir.
Which was called old times, it is called tuberculous pneumonia.
Yes, sir.
So these are the ways in which tuberculosis can affect the lungs. You got the point.
Yes,
And
sir.
of course, it can affect the pleura as well. So among these, if you are thinking of tuberculosis as the etiology, which is more likely in this patient?
Could be a fibrocavitary lesion
Why?
because hemoptysis
Hmm.
and there is a dry cough going on.
Hmm. What is the evidence of fibrosis here? Is it just a cavity? Can it be just a cavity?
Um, mm,
Hmm?
less
Yes.
likely. Less likely because
Fibrosis occurs afterwards. It's a replacement.
patient has
Yeah.
dyspnea for.
It's a cavitary tuberculosis. Possible, isn't it?
Yes.
And then what other disease apart from tuberculosis infection? You said something. Malignancy, you said,
Malignancy.
right?
Malignancy.
He's a heavy smoker.
Yes. Malignancy. Sir.
In which type of lung malignancy, breathlessness is a predominant symptom?
Bronchogenic carcinomas, adenocarcinoma.
No. Bronchogenic carcinoma only we are talking about. Which type? There are types, no?
Yes.
Yeah. What are the types you know of?
Small cell and non-small cell
Hmm.
carcinoma.
And what else? In which one breathlessness will be a predominant symptom? What is the reason? Due to malignancy.
Non-small cell, like
No. You're not getting the point. What type of lesion due to malignancy produces significant breathlessness? Have you heard of a term called bronchoria?
yes, sir.
What
Copious.
is it?
Yes, sir. Yes, sir.
Hello?
Yes, sir.
Can you
Yes.
hear me?
Yes, sir. We can hear you.
Yeah, there's some connectivity problem. So you may please proceed. Or if there's any other question.
Thank you. Thank you for that question. So let's go at 3 steps. What is your anatomical localizations? Make it more specific. And then we go into the pathology and etiology. So how would you summarize it?
And anatomical localization will be to the lung parenchyma or a pleura.
Interstitial.
More interstitial. Yes.
So if you say the main
Does
presentation,
pleural disease produce hemoptysis?
No, sir. Less likely. No.
so you have 2 symptoms, breathlessness and cough, right? Breathlessness, cough, and the cough is generally dry as you describe it. So breathlessness in a respiratory system affecting significantly the oxygenations in a more diffuse way. You are thinking in terms of parenchymal or interstitial. Both of them can have some cough, much more dry if you're looking at interstitium, more productive if it is a parenchymal. So you are just focus on the anatomical structure, then we can think of the pathology. So what's your pathology?
Pathology could be, for now, my differentials for the pathology will be malignancy, infection, inflammation.
So
Yes.
it is good to connect it with your history. So in a history, what cues you have for the pathology in this patient? Say, for
Yes.
example, if we say it's interstitium, okay, if that is anatomical localization in the respiratory system, what are the cues for pathology in this patient?
There is no fever, so less likely to be an infection. So I'm ruling out. There is history of loss of weight and appetite, which could suggest a malignancy. There is, other than that, there is only progressive cough and dyspnea, which can per se lead to a pathology like an ILD, interstitial lung disease like pathology.
Occupation?
And an occupation like
Dr. Rizwana, I think one cannot be all over the place. Now that you have given a foray of differentials, we have to come to a reasonable conclusion, right? Priority list.
Yes.
What are your priority list in this case? Here is a person, 3 significant points in the history. One is exposure to agricultural chemicals, right?
Yes.
2, heavy smoker.
Yes.
3, what is the third one?
Third one, he has
Allergy from childhood.
sorry, sir.
Allergy from childhood.
Childhood, yeah, allergic rhinitis.
3 points, key points in a respiratory case will lead you to some differentials. Can you zero down to those?
Yes, sir. This could very well be because he's a smoker with allergic history. This could very well be a obstructive lung disease,
Which one?
like an emphysema.
Hemoptysis.
Hemoptysis, when it could other differential will be again malignancy
uh,
or an
I
occupation.
think you haven't got that idea of formulating differential with a history. You cannot be, see, everything is possible in a patient with cough, but we have to prioritize. Otherwise, your investigations will be all over the place.
Yeah, I think we'll move on to the
Yeah.
examination
Move
part,
on. But
and then
I don't think Dr. Rizwana could fare well at this stage as a postgraduate examinee. We can move on.
So at this point of time, as Sir said, what are your priorities? One is exposures. What else?
Exposures. There's occupation exposure, smoking history,
Okay.
and there is history of allergy.
Smoking will help in which way?
Smoking has been associated with
Again, your
Yeah.
anatomical localization. So let's say if you put your anatomical localization as one as interstitium,
interstitial.
second as parenchyma, and third you may want to still put as airways,
Airways.
right? Pleura, you could put it, which can explain progressively increased pleural effusion causing breathlessness can be there, but there are some odd things you may want to put it much lower down. So if, as Sir said, if you want to put priority, where will your anatomical localization first be? Your first priority will
It'll
be
interstitium.
interstitium, second would be
Parenchyma,
third would be
airways, and down will be
airways,
pleural.
and last. So we
Would you
have
like to
these
put
4 areas.
parenchyma first because there's hemoptysis?
So, okay, so so we have both the possibilities, whether you'd want to put parenchyma as first and interstitial as second, or you'd want to put interstitium as first and second. And we have reasons. I mean, basically you should be able to justify whatever you are saying, right? So
And may
hemoptysis,
I add one more point?
yes, sir.
You said no seasonal variation, right? Right, Dr. Rizwana?
Yes, sir.
How many seasons will come in 6 months?
So you don't have seasons, right? So that's something that's important in the history.
That's
for
an automatism. You always say no seasonal, no postural. But seasons, you don't talk about seasonal variation in such shorter duration. It will be appropriate if you talk about someone having cough for many years, someone like a COPD by definition, cough with expectoration lasting for more than 3 consecutive months for 2 consecutive years. That kind of a thing, you can say seasonal variation.
So
Yes, sir.
sure. So if we have these 4 anatomical localizations, then when we go into pathology, what are your listing?
Pathology will be parenchymal disease. So infection.
Malignancy first.
Yes, sir.
Which one?
I'm suspecting malignancy first because there is no fever.
Oh,
So
changed.
malignancy first as the pathology, followed
Why
by the
malignancy first?
because there is
Is there any weight loss?
yes, sir, there is weight loss. There is weight
Weight
loss
loss is there. And
and
which malignancy will have associated significant breathlessness? Is it a common feature of malignancy?
not sure, sir.
In fact, if you ask him, any such patients, it is the breathlessness that is limiting him more. Functional limitation, isn't it?
Yes, sir.
Yeah, a few drops of blood, he may not bother. Of course, it's important for us.
Yes, sir.
So in which malignancy, breathlessness is a very significant symptom. Which type of malignancy? Bilateral, very, very virulent, aggressive malignancy in the lung, which is characterized by bronchoria.
Alveolar cell carcinoma.
Bronchoalveolar carcinoma. Maybe, yes. Yes, please.
Yeah, so that's one. Then you did say that there's occupational exposures. Keeping that in mind, whether you're putting it and the interstitial as one of the pathologies. Then you had smoking. Smoking can contribute in which all anatomical localization?
Airways
Airways is one, which is obvious, and
interstitium also.
interstitial. Which type of interstitial?
Like an
IPF.
IPF.
Right? So
idiopathic
IPF.
fibrosis.
So that's one of the differences when you're trying to differentiate NSIP and IPF, right? So keep in mind that smoking can affect in these 2 areas where you do not have a significant endobronchial symptoms. You are thinking in terms of a airways as a emphysema. That's what you said, right?
Yes.
So we are keeping all these things in mind. So keep the anatomical localizations in mind. Then go on to pathology in each of these areas. What are the possible pathological things? Your mind will be getting a little bit more clearer. And then with that, we will be able to zoom on the etiologies, right? So once you have done that exercise, then we know how we're going to proceed on for the others, right?
Yeah.
Go ahead.
One more point, if you don't mind, Dr. Rizwana. Can you hear me?
Yes, sir. Yes, sir, we can hear.
You should always mention about COVID infection in these patients nowadays.
Yes.
Either it is there or not, even vaccination. Because in the 70s, we used to say that if you know syphilis, you know half of medicine. In the 80s and 90s, we used to say if you know HIV, you know half of medicine. Now we say if you know COVID, you know half of medicine, meaning it affects all systems. So it's important to mention that negative history. Like you say, no history of tuberculosis. Similarly, mention about COVID in these patients always.
Yes.
Is there any history of COVID-19 infection?
I did not ask that history,
Oh,
sir.
yeah, it's very important. Can you tell us how COVID affects the lungs? What all pathologies?
Yes, sir. It can cause more like a atypical pneumonia. It can also
Yeah.
cause like an interstitial pneumonia, or it can cause a consolidation also with a superadded bacterial infection.
Mm-hmm. What is a typical presentation? Typical pulmonary involvement in COVID, which actually kills most of them.
More like an acute interstitial.
Interstitial. How do they die usually? How did they die? Okay. If others are okay, please carry on.
Just one more thing, a little bit detail on the occupational history. What was his exposure?
I asked about the chemicals. He was not able to tell clearly. He was explaining that it is used for like pesticides and fertilizers.
He's a shopkeeper.
He's a shopkeeper.
So is he opening it up?
Sorry,
Is he opening
he's
the?
handling it. He said he's used to handle it with his hands and without any personal protective equipments, and like a sprays, including the chemicals will be put in a sprays also.
But he's a shopkeeper,
He's a,
not a farmer.
like yeah, he gets it and then sells it to the people also.
Does he opens it, puts in different bottles and doing, or he just gets the bottles and sells it?
No. He uses it. He mixes it, something like that. He
does.
mentioned saying that he was using the chemicals, handling the chemicals.
So that is very important, that you need to ask that very specific. Just because he has got those chemicals in the shop, which are usually well sealed, may not necessarily give an exposure. So going into a little details becomes important, so that if you really want to attribute that exposure history should be very clearly said, right? Okay, go ahead.
On examination, he was thin built, moderately nourished, and his anthropometric measurements, weight-wise, he was 54 kilograms, height was 166 centimeters, BMI of 19.6, afebrile at the time of examination, blood pressure was 110/70, measured at the right arm in sitting position, pulse was 80 beats per minute, regular, normal volume.
What is the importance of radial pulse in any respiratory case?
Bounding pulse is seen in carbon dioxide retention, sir.
Okay. Any other? Any other?
Pulses
Can you get irregular pulse
in
related to respiratory? Pneumonia. Pneumonia. Then pulsus paradoxus.
Pulsus
Can you
paradoxus.
tell us what is pulsus paradoxus?
So there is a normally there is a drop in blood pressure during inspiration. If there is a exaggerated drop, that is a drop is more than 10 mm during inspiration, will is called as a pulsus paradoxus. It's an normally it is less than 10 mm. If the difference is more than 10 mm, it is called pulsus paradoxus. Seen in constrictive, cardiac tamponade,
Cardiac, okay.
and in pulmonary causes also some.
Which one?
Like pneumothorax.
Classically, it is described in which situation? Which respiratory?
Sorry, sir.
Classically, pulsus paradoxus is described in which respiratory case? Classically. Acute severe bronchial asthma, previously called status asthmaticus.
Yeah.
Can you attempt to tell the mechanism in 1 or 2 lines as PG?
In bronchial asthma, sir? Or
Yes. In bronchial asthma and constrictive, the mechanism is slightly different. The phenomenon is the same, but the mechanism is different.
Yes, sir. So normally in inspiration, there is a decreased venous return. So when there is I mean, in the sense, in constrictive pericarditis, especially there is because of the venous
Because in clinical viva, these questions, when it comes, you should be ready with a 1 or 2 line answer. We cannot take so much of time and, sentences to describe. Anyway, please read about that. Please continue.
respiratory rate was 20 per minute, abdominothoracic type. Saturation was 98% in room air. JVP was not elevated. General examination, he was pale. There was no clubbing, no cyanosis, icterus, lymphadenopathy or pedal edema. There was no
Just
flapping.
1 second. There is no clubbing.
Yes,
Is it?
no clubbing, sir.
Which are the diseases practically you are ruling out in the respiratory?
More like a
In
malignant.
other words, causes of clubbing, respiratory causes. Clubbing
Yes.
is a very important finding, particularly in respiratory cases.
Yes, sir. Malignancies.
Yes.
Then
Then.
Bronchiectasis.
Yes, suppurative lung diseases.
Suppurative
All
lung.
the 3. Bronchiectasis, lung abscess, and empyema. These 3 are the suppurative lung diseases.
Yes, sir.
Suppuration means first formation. Okay. Which else? Malignancy, suppurative lung diseases, and
Interstitial lung disease can
yes,
have
good.
clubbing, but
Yes, ILD.
yes, sir.
So when you say categorically that there is no clubbing, at least clinically, we should practically think of other causes for his problems.
Yes.
Okay. This is clinical.
Yes.
Okay, please.
There was no peripheral markers of tuberculosis or internal malignancy. No signs of connective tissue disease like fissuring, digital
For the
ulcerations.
sake of students listening, can you quickly tell us the peripheral markers? I'm sure
Yes,
you
sir.
know.
Yes, sir. For peripheral markers of tuberculosis, we can look for scrophulodema, lupus vulgaris, or flicton, choroid tubercles. And in internal malignancy, we can look for acanthosis nigricans, palmopanther keratoderma, choices, migratory thrombophlebitis. Or in, other than that, for connective tissue disease, we can look for skin thickening, joint.
Please stick on tuberculosis. You said no peripheral markers of tuberculosis. Please
Yes,
stick on to that. The others are for other diseases. Okay.
yes, sir.
Okay. Okay, please move on.
Yes. No, no supraclavicular lymphadenopathy, no signs of accessory muscle use.
Which particular node you are interested in a respiratory case in the neck? Particular node.
Left supraclavicular nodes.
In respiratory case.
In
That is very sure. That is different.
cervical and
No, particularly in malignancy, you hook your finger around a muscle and feel for a hard, particular hard lymph node. Typical in MD exam question.
scalene nodes.
Huh?
Scalene nodes. Not sure.
Are you there, Dr. Krishna?
It's supraclavicular. Respiratory system. So going on to the examination of respiratory system, upper respiratory tract, nasal mucosa appears normal. There is no deviated nasal septum or sinus tenderness. There is no nasal discharge crust or polyps. Oral cavity was, there was nicotine staining present with no halitosis. Gums, buccal mucosa, lips, tongue, tonsils and pharynx was normal.
Nicotine is not staining. The stain is due to the tar.
Tar.
Nicotine is colorless.
Tar staining.
Please continue.
Inspection, trachea appears to be central, chest wall is elliptical in shape, chest movements appear to be equal on both sides. The apical impulse is not visible. There was no drooping of shoulders, supraclavicular or infraclavicular hollowing, crowding of ribs or prominence of scapular borders. There was no chest wall deformities, no
Okay.
scars.
Can you please tell us respiratory conditions that will come to your mind if the trachea is central clinically?
Could be a bilateral lung disease, sir.
No, that is very rare. That is stretching the imagination. Tell us the common ones.
Bronchiectasis can have, but sir, bilateral pleural effusion, bronchiectasis, interstitial lung disease, pulmonary, pulmonary embolism.
Trachea central, common presence of clubbing, close towards the final diagnosis.
Sorry, sir.
I think you didn't expect that kind of a question, but you know the answer. Is the trachea central in COPD? Is it central in bronchial asthma?
Yes, sir.
So essentially, bilateral diseases, isn't it? No
Yes.
push, no pull.
Yes, sir.
Yeah. So that's a simple thing. So hemoptysis, clubbing, and position of trachea will solve the problem almost 90%, even before you examine further. Are you getting the clue?
Yes, sir.
I hope you understand. Please continue.
Palpation, trachea was deviated to the right, but trail sign was negative. Apical impulse was felt in the left fifth intercostal space, half an
What
inch.
is the importance of train sign? You know what train sign is, but what is the importance in such case?
Sometimes, even physiologically, sometimes trachea is mildly deviated to the right.
Yes. Yes.
So if trail sign is negative, this could not be a.
Yes, you are right. You are in the right track. Trachea position normal is either central or slight deviation to right. But in a right side deviated trachea, if trail sign is also present, it is not normal deviation, it is pathological. That is the significance.
Yes, sir.
Okay, thank you. Continue.
The cricosternal distance was 2 fingers. The chest movements were equal bilaterally. The anteroposterior diameter was 24 centimeters. Transverse diameter was 33 centimeters with a ratio of 5:6.9. There was no subcutaneous emphysema, rib crowding, or intercostal tenderness. Chest measurements, the chest circumference was 90 centimeter in deep inspiration and expiration it was 87 with a chest expansion of 3 centimeters. Right hemithorax expansion was 1.5 centimeters and left was 1.5 centimeters. Spinoscapular distance was 9 centimeter on both sides. Spinoacromial was 14 centimeters on both sides.
So far with your measurements, you're talking about a bilateral disease, right?
Yes, sir. Yes, sir. Bilateral disease.
Yeah, this is a crucial thinking in respiratory case. The next crucial thinking, hemoptysis, clubbing, position of trachea, and then are we dealing with a unilateral disease or a bilateral disease? That is the next crucial thinking. Understand? And what else you should mention when there is significant breathlessness in the history on inspection?
Accessory muscle use.
Yeah, that is okay. Good. Anything else? Intercostal indrawing.
Drawing.
Is it present?
No, sir.
What is its significance? The significance. If there is intercostal indrawing in a particular area, what does it suggest?
Especially in obstructive airway disease, the diaphragm.
It just says that the underlying lung is not expanding normally. That's all. So it can be fibrosis or any other such condition where the underlying lung is not expanding normally. That's all. No specific disease. Okay? Yeah.
Vocal fremitus was equal bilaterally in all 9 areas. Percussion, direct percussion was resonant, and other
Can
areas
you
of
name the posterior areas? What are the areas posteriorly?
suprascapular, infrascapular, and interscapular areas, sir.
How many interscapular area?
Small. Oh. One.
Suprascapular, left and right.
Left and right. Interst
Infrascapular, left and right. Interscapular,
is one.
only one. No,
I mean,
this is
it's
a
on
common
both sides.
mistake. Interscapular is the area between the spine and the medial border of the scapula.
Both.
On both sides, there are two. Even interscapular, there are two. Please remember that. All respiratory areas are paired. Please continue.
Chronic systemus was resonant. Tidal percussion. Dullness was noted in the right sixth intercostal space and midclavicular line, and it disappears on deep inspiration. Top space was tympanic, no straight line or shifting dullness. Lung margin corresponds to sixth rib anteriorly, eighth rib in the metaxillary, and T10 vertebra posteriorly. On auscultation,
What is DS spine sign? Straight from the book.
so there is increased bronchial breath sounds below T4 level. Is suggestive of a mediastinal, posterior mediastinal or middle mediastinal mass, which is causing the bronchial breath sounds. Normally, it
Okay,
is.
good, good. Now, so far, before you auscultate, what are the positive findings in respiratory examination?
So far,
Please put it together.
there is mild decrease in chest expansion, but otherwise, it's looking like a bilateral lung disease, sir.
So no other positive findings.
No
What
other.
is that mild decrease? How much is that?
I mean, it's only it's 3 centimeters, sir. Chest expansion is 3 centimeters.
Contributed from each side, right?
Yes, sir.
Equally contributed.
Equally
Okay.
contributed.
Any other findings?
No, sir. So far, no positive findings.
So your auscultation is going to be crucial, if at all. Yes, please continue.
In auscultation, the positive finding was there was end inspiratory velcro crepitations heard in the infraaxillary, bilateral infraaxillary and infrascapular areas.
Very typical textbook description. Okay, end inspiratory velcro crepitations. Can you tell any other type of crepitation?
Yes, sir. In mid inspiratory, early inspiratory, I mean, especially in pulmonary edema, we can hear
Fine crepitations.
fine
Okay,
crepitations.
any other?
Coarse crepitations and coarse leathery crepitations in bronchiectasis.
Good.
And
Have you heard of a terminology called medium crepitations? Books write that.
no, sir. I'm not
Please
heard of.
read up. It's described medium. Fine is there, the coarse is there, leathery, and medium. Anyway, this is end inspiratory. So when you say that, it's like telling a mid-diastolic murmur with opening snap, and then it has to be mitral stenosis. Am I right?
Yes, sir.
There's nowhere else to go, practically. Okay, let's hear further.
Vocal resonance was also equal on both sides. Other system examination, cardiovascular, normal S1 and normal S2 heard, no murmurs. Abdomen was soft, non-tender, no organomegaly or shifting dullness. CNS, there was no focal neurological deficits. Summary,
What particular things you will look for in the cardiac examination, not cardiovascular, cardiac examination in a patient with such respiratory disease?
I would look for pulmonary hypertension, like a loud S2. And I'll also look for right ventricular failure, some failure signs, like elevated JVP, pedal edema, and right heart border.
Good. So what is that situation called?
Cor pulmonale.
What is cor pulmonale? Can you define again? Chronic cor pulmonale.
Right
It's better to say
ventricular
chronic cor pulmonale because there's an acute cor pulmonale as well. What is that?
The right ventricular failure secondary to a chronic lung.
No. What is acute cor pulmonale?
Acute.
That's another name for acute pulmonary embolism.
Yes, sir.
Okay. So what is cor pulmonale? Chronic cor pulmonale by definition?
A right ventricular failure secondary to a.
No, ma'am, no. It is right ventricular hypertrophy with or without failure. Please remember. No, you need not get failure signs. only a hypertrophy is enough to call it as chronic or pulmonary. Please remember that. That is, if the pulses, ventricular, right ventricular pulsation is felt in the epigastrium, touching the tip of your thumb, and also left parasternal, only without right ventricular failure signs, you still call it chronic or pulmonary. Failure not necessary. Please continue.
Summarizing, a 67-year-old gentleman who's a chronic smoker and has occupational exposure to agrochemicals presented with history of progressive dyspnea with a non-productive cough for past 6 months. On examination, there was reduced chest expansion bilaterally and bilateral basal velcro crepitations on auscultation. So my diagnosis with anatomical localization being bilateral lower lobe interstitial disease. Sorry for the typing error. Then pathology-wise, it's I will think of an interstitial lung disease. Etiology being related to smoking or occupational exposure, or it could be idiopathic pulmonary fibrosis too. There was no signs of respiratory failure or cor pulmonale. With this thing, I'm going on to the differentials of idiopathic pulmonary fibrosis or a chronic hypersensitivity pneumonitis, or it could be a combined pulmonary fibrosis and an emphysema, or a respiratory bronchiolitis type of ILD.
Oh, so many things. Nice. So, interstitial lung disease affecting only the lower lobes, you said.
Yes, sir. In clinical examination.
Findings are only in the lower lobes.
Clinical examination.
Yes, on examination.
Yes, sir.
Crepitations only in the lower lobes.
Lower lobes.
Is it little bit too much? Like interstitial lung disease usually produces findings in all lung fields, all lung areas, right?
No, sir. Certain ILDs are.
Which are those? I was coming to that.
Yes, especially idiopathic pulmonary fibrosis is more in the lower lobes, and
It's more in the lower lobes. Please remember,
predominant.
more. But it has to be, interstitium is there everywhere.
Yes.
Any insult that happens has to affect everywhere. It's
Yes.
more. That's okay. And then
Upper lobe wise, it is hypersensitivity pneumonitis, silicosis, pneumoconiosis usually predominantly affects the upper lobes.
okay. Now defend or you said it is Velcro. That is very typical. So someone else auscultates and say this is not Velcro. So is it possible that this can be a case of bilateral bronchiectasis?
But there is no history of a productive cough in the background, sir. There is only dry cough. And
Okay. Hemoptysis is there. Is hemoptysis common in interstitial lung disease?
Less
Yeah,
common.
it's not common. It's only the interstitium. Parenchyma is not affected. No blood. So we can argue it that way. So is it possible that it is bilateral bronchiectasis? Question again. Will you keep it as a second differential diagnosis in view of the hemoptysis?
Yes, sir. Maybe at the last.
Huh? You
Yes,
will.
sir. Down the line. Down the line, I might consider.
Down the line, you will consider. But no clubbing. See, never trust your examiners in MD exam. They will take you to all sorts of places, but you should stick on to your guns as much as possible and then argue out. Okay. No clubbing. Classically, we say suppurative lung diseases are clinically diagnosed only with the presence of clubbing. No halitosis, nothing is there. So is it possible?
Sir,
We are not sure.
Dr. Krishna Richa here. So sorry to defy you on this. Clubbing should be there in suppurative lung disease. So that's an old learning now, because with the advent of antibiotics and with the advent of early diagnosis, you hardly get clubbing in patients with suppurative lung disease, even including bronchiectasis. So we would see only in.
My point was just simple, madam. To make a clinical diagnosis of bronchiectasis, clubbing is required. Clinical diagnosis. We are clinical. Anyway, I accept your point. So it's new information for me. Clubbing need not be there to make a clinical diagnosis of bronchiectasis. Okay. Well and good. I accept that. I'll keep it in my mind. Thank you.
Dr. Rizwana, I would like to ask you about the 4 differentials which you have given. What do you think among the 4 is the most likely diagnosis in this patient? This is all based on the history is there and your examination finding. Among the 4, which is the most likely diagnosis?
I would put
And the reason for that?
I would put idiopathic pulmonary fibrosis with the point supporting it is starting from history. There is history of smoking, which is associated with idiopathic pulmonary fibrosis. And
Madam, I would like to interfere a little bit. When you say idiopathic, you attribute that to smoking, then there's an etiology.
I mean, it's associated, smoking is associated with idiopathic pulmonary fibrosis.
Then how can you call it idiopathic? You are saying because of smoking.
I would have a bit of difference of opinion
Yeah,
here,
please.
Anna. I would rather say when you are saying idiopathic pulmonary fibrosis as the most likely diagnosis, I would differ. Reason being,
That's what. I agree
your
with
lung findings, the expansion of the lung, or for that means the margins of the lung are all normal, right? So in that scenario, so if you have an interstitial lung disease, usually you will have small lung volumes, whereas in here the lung volumes are all maintained according to the clinical examination. So in that scenario, which is the most likely diagnosis here now?
CPFA.
Yes, combined pulmonary fibrosis and emphysema is the most likely diagnosis with your clinical examination and history, because the lung volumes are maintained. You have classical Velcro crabs, which are basal, and which is classical of interstitial lung disease or UIP pattern, or for that matter, any ILD. And emphysema, why I'm saying, because there is a history of a smoking, he's elderly, and the lung volumes are maintained.
Going a little wilder, you said this patient's father suffered from cirrhosis of liver. Now he has a chronic lung disease. Can you connect?
Yes, sir. Could be related to an alpha-1 antitrypsin deficiency.
Excellent. Very good. Very good. Okay, we have to think. I mean, I'm not pinpointing that it is, but then sometimes these things do come. Good answer.
So, shall I move on to the investigation?
Okay, so what do you mean by idiopathic pulmonary fibrosis?
And it is a type of interstitial lung disease. It is the most common interstitial. It's
So basically,
predominantly involves lower lobes, which causes characteristic radiological and pathological findings. Radiological findings being honeycombing with there is a traction bronchiectasis, honeycombing, and reticulations, predominantly in the subpleural lower lobes. And pathologically, there is a lot of fibroblasts and predominantly occurs in elderly age group.
right. So when we say idiopathic pulmonary fibrosis, as Dr. Krishna has rightly said, we don't have any reason for it. But the pattern what you are describing is actually UIP, usual interstitial pneumonitis. Now, when UIP is associated with no cause identified, it is called as idiopathic. So until now, you cannot say. You may say that this is a lower lobe predominant interstitial lung disease in an elderly patient with more than 3 months of history. Probably UIP is the pattern because you don't have any clinical signs and symptoms suggestive of CTD. History of exposure is there, but then patient doesn't give any histories of exacerbations in between. Normally, hypersensitivity pneumonitis would have upper lobe predominance first, and they do have those episodes of exacerbation in between and then go off. So then what are the other ILDs which may be lower lobe predominant? So one we said UIP pattern. What are the other ones?
NSIP.
Okay.
Other than Only the patterns.
Only the patterns, yeah.
Lymphos.
LIP, it is
LIP.
mostly diffuse actually, but you are rightly said UIP and NSIP are the more common pattern which are lower lobe predominant. Upper lobe you have already told us, right? Sarcoidosis, hypersensitivity pneumonitis, occupational lung disease, and even sometimes CTD related lung diseases, especially rheumatoid, is also upper lobe predominant. So how would you go further in this patient?
Just one point before that, if you don't mind.
Yes,
Yes,
please,
sir.
please go ahead.
Hello.
Yes, please go ahead.
Yeah, yeah. Now that you have made a diagnosis of interstitial fibrosis, retrospectively, it would be better if you could mention some of the general examination, specific general examination findings you would have looked for. I mean, retrospectively. Can you tell us?
Yes, sir. We'll have to look for clubbing.
Yeah, that you already told.
Yes,
Apart from what you already told.
we'll have to look for peripheral, signs of connective tissue diseases,
Such as?
like skin thickening, um, skin thickening, Raynaud's, joint swelling, skin rashes. If it's sarcoidosis, we have to look for lupus perineo.
Okay. Now,
If-
this is a 70-plus-year-old elderly man. At this age, which connective tissue disorder manifests first time? First time. He never had anything in the past. Generally, they manifest very early in there, and usually females. Anyway, so at this age, which connective tissue disorder surfaces at this age?
Scleroderma, we can look for, sir.
What is the patient's age? 70.
Age, sir, 67.
67. Yeah, yeah. You think scleroderma comes first time at 67?
No, sir.
Which connective tissue disorder can remain questions without manifestation for decades? Only when it involves some of the target organs, you get a clue.
Not sure, sir.
Yeah, it's okay. Please carry on. There's a connection problem. In between, I didn't hear what you said. Am I audible?
Yes, sir. Yes,
Yeah,
sir.
yeah. I think you got my question.
Yes, sir.
Yeah. Which connective tissue disorder manifests so late?
I'm not sure, sir.
Please read up. Please read up. Generally, it's in the 20s and 30s, predominantly females. You know all those.
Yes, sir.
Yeah, please continue. Please continue. I think I'm not audible. Hello?
Yes, sir.
Good with your investigation.
So I would like to evaluate, beginning with a chest X-ray to confirm my
Yeah.
diagnosis. I'll initially start with a chest X-ray, do pulmonary function tests like spirometry, lung volumes.
Why pulmonary function test? Please tell, I mean, when as a postgraduate, when you talk about any investigation, just one line you should tell what is the importance and or why do you want that investigation? To look for what?
To look for reduced FEV1, FVC, to look for lung
Mm-hmm.
volume.
Mm-hmm.
And then I'll go
Right.
on.
I mean, FEV1, FVC ratio, what?
FEV1, FVC ratio might be normal.
Hmm?
In an interstitial lung disease, FEV1,
Normal.
yes, sir, could be normal because both FEV1 and FVC is reduced. So FEV1 by
What is
FEV1.
classical?
Sorry,
Would
sir.
be normal, maybe, yes.
No.
Anything is possible in medicine. FVV1 by FVC classically what? In interstitial lung disease is restrictive or obstructive?
Restrictive, sir. So both FEV1 and FVC will be reduced.
Yeah.
And FEV1 by FVC.
Yeah, that is a typical. Okay. In chest X-ray,
Decrease.
what do you want to look for in this with this clinical diagnosis?
In chest X-ray, sir.
Yes, that's the one you said first.
Yes, sir.
And naturally, that's the first investigation mostly. Yes. What do you expect in this patient's chest
Chest
X-ray?
X-ray predominantly expect reticulations in the bilateral lower lobes.
Mhm.
And
Can it be normal?
yes, sir. Yes, sir. If it's in the initial stage, it can be normal.
In this patient, which one will you vote for? Normal or
So here the findings are very minimal, so could be normal, can be normal, sir. Because there is no lung loss of volumes. Sir,
So, sorry, I'm just coming. So,
only?
hello. Yes. So I'm just coming here.
Yes,
Now
please.
you
Sir.
have two. I
Yes,
mean,
sir.
in your differentials, you're giving us a combination of two kind of a disease pathology. So this is a good time for you to, in your investigations, highlight that part, right? So just don't go into rattle down the list of things you have. You already have it in your mind. So in your PFT, what will be your interest that you would be wanting to look at? Similarly, in the X-ray, now become a more specific. In X-ray, you did talk about two different kinds of ILDs. So what are the features that will differentiate one from the others? Not now we are not looking at the features of ILD. ILD is almost kind of, it's a diagnosis already made. Now we are looking at what is qualifying me a little better than what it was, will make your list of investigations approach, make it more specific so that we come and zoom down on the final diagnosis that we are thinking about, right? So on PFT, you have the PFT reports.
sir, I have the
Yes, very good question.
So you tell us in that PFT, what did you find? Was it what were the findings? How much of obstructive, how much of restrictive finding was there? What was the combinations of it?
Sir, here in this patient, since we consider CPFE also, so emphysematous changes in the chest X-ray can be there. We can look for that. In PFT also, we can expect an obstructive pattern also because he has, we are suspecting it. This is the chest X-ray of the patient, which is showing bilateral lower zone reticular opacities with hyperinflation also. And in HRCT, these are the HRCT cuts from the lower lobes, which is showing honeycombing pattern with reticulations and this is the spirometry PFT, which is showing actually normal FEC, normal FE1 and normal FE1 by FEC ratio. And DLCO was also quite normal for this patient.
When we go to the PFT, right? So if we look at the PFT, the very first thing in any spirometry, which is the first part of it up till PIF, we will look at FEV1 by FVC ratio, the pre-ratio, which is 80.72. That means it is normal, right? When it is normal, you exclude obstructive airway disease. So then you jump to FVC. Percentage pre is 89%. So again, this is normal, okay? Once this is normal, then you have to look into the lung volumes because you are looking at whether this is a restrictive or obstructive airway disease. Ideally, with this spirometry, you don't need to require to do anything else. But since we are suspecting ILD, we have to do advanced lung functions. And if you look into the TLC, it is reduced. It is 68%. So that means there is reduction in the lung volumes. RV by TLC is 52, which is also decreased, surprisingly. If we are suspecting that this patient may have a concomitant obstructive airway disease or emphysema, then usually RV by TLC is increased, which suggests air trapping, which is not there. Then coming to the DLCO is normal, which is again a bit surprising because ideally in a interstitial lung disease, DLCO is the first parameter which goes down. But at the same time, if you look the ventilation part of it, VA single breath, which is decreased. So that means there is a combination of things which is happening. There is some damage to the alveoli or parenchyma, and there is interstitial involvement. That is why our DLCO by VA is coming normal, is what I would feel. So probably to me, based on this, because we have a clinical history now that we have seen a CT scan also, though we haven't seen the entire cuts, probably this patient is having emphysema as well.
Before we go to scan, just before we go to the CT scan, can I ask her one question?
Yes, sir. Yes, sir.
Dr. Rizwana, can you hear me?
Yes, sir.
Hello.
Yes, sir. We can hear.
Can you hear me, please?
Yes, sir.
We
Hello.
can
Yes, sir. Yes, sir. We can hear.
we can hear you,
Yeah.
Dr. Krishna. Your voice is breaking a little bit.
Most of the values are normal. X-ray normal, everything normal. He's breathless. Is it a case of heart failure? Bilateral basal crepitations? Is it altogether cardiac? Case of heart failure. You're a
No, sir. No.
oh, sorry. You're
The
a
repetitions were not.
general physician, and the adage goes that all that we
So we are not able to hear you. Not audible. Is the HRCT of the patient is showing some emphysematous changes in the right and subpleural honeycombing with reticulation of it. Traction bronchitis. Yes.
And there are what areas of
Emphysematous and
in this patient. So this CT, Rizwana, you want to describe?
yes, ma'am. So
Describe.
it's showing something. From the upper lobes, we see there is emphysematous bullae in the right upper lobes. As we go lower down, middle lobes are normal, but in the lower lobes, we can see subpleural reticulation
lobe?
and with
Middle lobes?
cysts and honeycombing because it's
I think she's not hearing. The connection problem is there. Madam, did you say middle lobes?
no, sir. Middle lobes were normal.
So I think if you would have to say it is subpleural involvement is there in terms of reticular pattern with some traction bronchiectasis, but the involvement in lower lobes is much more compared to the upper lobe. That is one thing. So subpleural bilateral basal predominant ILD is what we are looking at. There is also, apart from traction bronchiectasis, there are cystic spaces or which are in two layers, which we say is honeycombing. Upper lobes, upper zones or lobes, if we are going, we are seeing those emphysematous changes as well. So this is very classical, though surprisingly PFT is very much normal. This patient has lower lobe predominant interstitial lung disease because honeycombing is there, because no ground glassing, age is in factor. This will be favoring UIP pattern, very typical UIP pattern, and upper lobe predominant emphysema. So this may qualify for CPFE.
Thank you very much, madam. Very good description. Thank you. I learned a bit from that. Thank you very much. Rizwana,
Yes, sir.
On the ground, during rounds, practically, you see this and you see a normal PFT. Practically,
Yes, sir.
what will you do? Because it's discordant, isn't it? You have
Yes,
so many changes in the radiological investigations. PFT is normal. So what will you do?
we'd
Practical
look,
question, very practical.
we'd look for other causes for his dyspnea
No,
also.
no, no. Wait. Before that, there is an anomaly, isn't it? You cannot explain this. So what will you do? I'm not asking any other theoretical point. Practically during rounds, if I am at in your place, I will repeat that PFT. Before that, I'll check the name and hospital number and all those of that PFT. Isn't it, madam? Isn't it sensible to do that?
Yes, sir.
When two
Absolutely agree with you,
investigations,
sir.
yeah,
Absolutely, we have to
we see
check
so
that.
many human errors. Medication error is the fourth most common cause of death in US. Human error. So I will look again at the name and hospital number of that investigation, and then I will repeat it. You don't know. Instead of one Chellappa, they would have done another Chellappa. I'm talking very seriously. No, I'm sure all the seniors will agree with me. Isn't it, madam?
I think it's a very important point. I think something that on bedside we always teach our patients.
Yes.
Sometimes we tell them to take a salt restricted diet, and
Mm.
the dietitians leave these small packets of the salt. They have the normal diet and they add this additional salt on that. Sometimes you literally have to check all those things on the bedside. I
Yeah,
think
yeah.
that's all this age and
Very
experience
important.
do
Thank you, sir. Very
tell us that
important point.
we should not take it for granted. So I think it's
Yeah,
very
we
very
have seen for a thyroidectomy patient, the preparation was for hemorrhoidectomy because they mistook the patient. It happened really seriously.
I know.
So please, Dr. Rizwana, human error is always there anywhere in the world. You know about the mother of Sri Devi, the actress, great actress, who was operated on the wrong side by a neurosurgeon in New York. The skull was opened on the wrong side for a brain tumor surgery. So this is just a by the way point, since it's a clinical discussion.
So
Yeah.
thank you,
Ah,
Dr. Krishnan. So, thank you, Rizwana. I think what we, just to sum up what we went through, very important is as you go through the histories, good to put all the important history
yes.
together and always construct it going through this three-step method. We find it much easier. Most of the time, PGs jump into the etiology. Never start with etiology. Start with an
True.
because in this patient, it was not in one location, right? It was a combinations, most likely. We have not really shown, but keep that in mind. Settle the anatomy, think of the pathology, and in history itself, you're getting a lot of cues regarding the pathology, and then you make your pathology. And so when we have done this construction, then you affirm those things in your examinations. And when you're interpreting the results, as Dr. Krishna also pointed out, make sure you're seeing the same X-ray of the same patient and not something else. Because if it is, I mean, your ego should be much higher to say, no, I am not going to accept it as far
Yeah.
is what it should be. I think that's a very important point that has come in. So
Very well said, sir. Very well said. Thank you.
yeah, so when you do that, you won't be very far away from the diagnosis. And then your additional reading point is the classifications of ILDs, the distributions of the lesions. How do you differentiate, say, IPF from NICP? And what can we still diagnose at the level of X-rays? Many places you may not have CT, but really
Yes.
speaking, CT findings you should predict. You should not see the findings. You should predict that in CT I'll see this.
Mm.
But even if I'm in a small mission hospital, it's okay. My diagnosis is as close to what it could be. And so that shows
Otanjatram.
clinical confidence that you should have. And I think you have nicely presented and nicely discussed.
Yeah. Very good presentation. Nice, clear presentation, and a lot of points. A few points which I could add.
Yes,
If you
sir.
keep in mind, it'll be useful for your MD exam, such as COVID, because we teach our postgraduates always to mention about COVID in almost every case as a significant past history. So well presented, Rizwana. Thank you.
Thank you, sir.
Very well done, Rizwana. Just a very quick question. Suppose this is UIP. And not in this patient. This patient is elderly and or maybe this patient only, the PFT is not good and this is UIP pattern. What are the options of drugs you would like to offer for this patient? And this UIP, when I say it is IPF, right? Not CTD related, it's IPF. What options do you have for this patient?
Medications wise, I can start on antifibrotics like nintedanib and pirfenidone.
Okay. So among the two, which one you would feel is you would start in this patient, particularly in this patient?
Nintedanib or
So we have only two antifibrotics, right? Nintedanib or pirfenidone, and both are approved by FDA for
Okay.
use. But in this particular patient, I'm asking. For that, you should know what are the side effects related to it, right? Just a reading, you can do it. Nintedanib has the common side effect of decreased appetite and weight loss, whereas pirfenidone has more of the skin rashes and all. This patient already is having a history of decreased appetite and weight loss. So further adding on, if there is something sinister going on, will be a little difficult for us to identify whether it is because of sinister lesion going on or it is because of the drug. Very common side effect. Most of our patients will come back saying that they are not able to eat and weight loss is there. One thing. Also, pirfenidone is considered a little safer if the patient have an underlying cardiac disease and your patient has CAD, right? So in this patient, ideal drug, if you want to start antifibrotic, would be pirfenidone. Thank you so much.
Thank you, madam. Very good points, very valid points. One, I am an old physician, very old. So I would be happy if you start your management plan by telling the patient to stop smoking. Very basic, but isn't it important for us? Yeah, then you go for all the antifibrotics because old timers, we like to go for the basics, even as undergrad. Another point I would like to tell you is such cases, particularly respiratory cases, please present both as a long case and a short case. The approach will be totally different without history. Same case is given as short case, the approach will be different. The discussion will be different. So it's ideal that you postgraduates, when you discuss a case, discuss the same case as a long case with history and a short case without any history. You will see so many other possibilities coming out.
Yeah, I think, thank you, Dr. Krishnan. Really
Thank
appreciated
you.
your discussions that you brought in. I think our PGs are being exposed. This is like a preparations for them for the final exams. We'll have examiners like you coming. And this, I really appreciate.
I was there 2 weeks back as family medicine MD examiner with Dr.
Okay.
Venkatesh.
Okay.
2 weeks back
Okay.
in Vellore,
Thank you so much.
in
So
that
thank you so much.
peripheral hospital.
Sure. Thank you so much for all the inputs from you, Dr. Krishnan. And thank you, Dr.
Thank
Richa,
you, sir.
for
Thank you
taking
for
time.
involving me.
Sure.
And
Thank
thank
you,
you,
Richa.
Rizwana, to choose a good case and present.
Thank you.
So thank you, Dr. Richa, for coming and representing
Thank you,
from
ma'am.
Department of Respiratory Medicine. There's a lot of teaching that went in. Many of us also learned through it. And Rizwana, once again, want to thank you for your presentations and all our
Thank you.
PGs and our consultants who are there. I hope numbers should go up with time. So thank you once again. And thank you, Jonathan and Dr. Ramya, for leading these sessions week after week. Thank you so much.
We can end the meeting, Hexagon team. Thank you.